Good morning or afternoon or evening. So this video is about radical nephrectomy, specifically robotic radical nephrectomy. Rarely to remove the kidney, we do have to make a large incision to get the kidney out, and that would be an open nephrectomy rather than a robotic or laparoscopic nephrectomy. But now the vast majority of the time we can remove the kidney with the robot. It's very helpful in terms of pain, the amount of fluid loss during surgery, blood loss during surgery. And so when we can use the robot, we do that. So as far as expectations for the surgery, I assume you already watched the first video about why we would choose a radical nephrectomy for your particular tumor. Also, obviously, your conversation with me in the office. So as far as expectations for surgery, the surgery is done at a hospital where you're going to stay. Usually it's 2 nights. When patients have the nephrectomy, the left kidney removed, they tend to recover a little bit quicker because there's a little bit less nausea involved. On the right side, there's a special piece of bowel called the duodenum, and I have to move that over to get the right kidney out. That piece of bowel, when you do anything to it, when you touch it at all, it can cause some nausea. So those patients that have the right kidney removed usually also go home the second day. Honestly, it's more at this point a situation where on the left side you probably go home right away in the morning, and then on the right side maybe you'll go home in like the late afternoon or something like that. Sometimes you have to stay for a third day. There'll be very small incisions. So there we go. I have to lose weight. Okay, so you have these small robotic incisions. If it's on the left side, say this is my right side, but say it's the left side, it's going to be 1, 2, 3, 4 incisions like this, and then there will be an incision here. Most of the case, I'm operating with a small incision, but at the end of the case, I have to get the kidney out. So I do extend this particular incision just big enough to get my hand in there. So it's about that big. On the right side, it's basically the same, except there's another incision way up top, right here in the center, and that's for a retractor to hold the liver back. So there's one extra small incision. All the small incisions, you probably won't feel at all. The big incision can be a little bit uncomfortable. I use a muscle sparing technique to make that as comfortable as possible. It's certainly nothing like the pain from like when you get this incision. Um, it's much less pain. But there is some discomfort associated with that incision, and you will go home with some pain medicines. Risk of, surgery, there are some risks, although, done robotically, really, this is a safe surgery done in experienced hands. This can be somewhat technically challenging, especially for people who are just starting out and dissecting the renal vessels. There are, risks associated with that. So as far as working with an experienced surgeon, I've done hundreds of these at this point, and I'm getting referrals from all over to deal with the kidney masses, which is great for me. We're looking to get more people in the area doing robotic surgery and doing these cancer cases so that we have better coverage. But for now, I have been dealing with a lot of the kidneys. So as far as risk go, it's a 2% risk of significant bleeding, 2% risk of significant infection, uh, a 2%, usually it's 1%, but because I have to extend the incision, there's a 2% risk of any wound complications like a hernia, a 1% risk of any injury to the bowel around the kidney if you've not had an abdominal procedure before. If you have had an abdominal procedure, it kind of depends on what you had as far as how high that risk ends up going. If I'm going to do a robotic approach, it really would not be more than a 5 to 10% risk of a bowel injury trying to get into the abdomen. If it was a higher risk than that, then that'd be one scenario where I would be like, what, we have to do this open instead of trying to do a robotic. And then there's a very small risk of the cancer coming back, and that would be determined by your final pathology. So after surgery, which takes about an hour and a half, maybe 2 hours. After surgery, you'll go to the recovery area. You'll be in the recovery area for a couple of hours, and then you'll head up to your room. After surgery, I do give a call to whoever you designate as the person to notify when you come in and get registered, and let them know how the surgery went. I won't really know much about the pathology and what's going on exactly with the cancer until I see you back in clinic. When I remove the kidney, I remove all the fat around the kidney to get margins, because all that fat, it's not doing you any good anyway. You lose some weight with a radical nephrectomy because there's sometimes a lot of fat around the kidney. For bigger patients, it can be 10, 15 pounds of weight loss, but it's just fat coming out. Either way, those are the surgical margins. And so I don't even see the mass most of the time, unless it's a very big mass. Sometimes you do see the mass, but most of the time you don't see the mass at all. You just see this big thing of fat and then the little blood vessels coming out of it. And that's kind of the whole procedure, is controlling those very big blood vessels and then just kind of coring the whole thing out and getting it out of the patient. So I don't know postoperatively anything more than I did when I saw the images in the office, until the pathology comes back. For the pathology to come back, it has to, get set in this formalin, formaldehyde, basically, for 3 days. And then the pathologist cuts it all up and looks at every individual slide and puts stains on it and markers to see if it is cancer, and also what type of cancer it is. Is it a clear cell? Is it a renal? Is it a chromophobe? Is it a papillary? There are different subtypes of renal cell carcinoma. And then they come out, with the final answer of the type, the grade, and the amount of invasion. Did it extend outside of the kidney, et cetera? That is all information we will review at follow-up. And we won't know that until then. So then you'll be in the hospital, you'll be on some IV fluids. At first, you're going to get like soup and jello because you may get nauseous, and we don't want you to throw up, a hamburger. And that can be complicated because you can then breathe that in and it creates a horrible pneumonia. So, jello is not as bad in that scenario. So we do soup and jello until, usually the second day, like post-op. So like the day of surgery is the day of surgery, post-op day 1, and then post-op day 2. Beginning of post-op day 2, usually we transition you to regular food, shut off the IV fluids. We want you to be walking the whole time. The day of surgery, probably not, but the first day after surgery, we do want you up out of bed, walking out at least to the door of the room 3 times a day. If your nurse isn't asking you to do that, please, ask your nurse, hey, I want to go for a walk, and she'll disconnect everything, blah, blah. There will be a catheter coming from your bladder when you wake up from surgery. That will get taken out the next day. It does not hurt when it is removed. And the reason for that is so that you don't have to get up in the middle of the night and go to the bathroom a bunch of times right after surgery. That urine will just passively drain into the catheter, and you won't have to worry about that. And we'll just follow how you do with the meals and also your laboratory work. Generally speaking, this is not a large blood loss surgery. Sometimes there is some blood loss. It's pretty rare when I have to do a blood transfusion for a radical nephrectomy, even if, unless it's an open and the patient already has a low blood count to begin with, because these tumors can become so big, it interrupts your ability to make your own blood cells, and people start off very anemic. And so those situations, people can end up with a blood transfusion, but the vast majority of the time, there's no blood transfusion, there's little blood loss, and those labs are okay. The lab that we do pay attention to a lot with this surgery is the renal function. Because I'm removing a kidney, your renal function is going to change. Sometimes it doesn't really change very much. Sometimes it changes significantly. If you already have trouble with your renal function going into the surgery, this is not going to make it better. And almost certainly, if you've had some trouble with renal function going into the surgery, I'm going to ask that you see a nephrologist, as an outpatient. And people always ask what's the difference between nephrology and urology. Urology are like the surgeons for the kidney and the urinary tract. And then nephrologists are the medical doctors for the kidney specifically. They do a lot of like dialysis and also medication adjustments to prevent you from going on dialysis. If there's a chance that you're going to end up on dialysis, you'll know that way ahead of time. Uh, I don't think I maybe put like ended up with one person that wasn't on dialysis that ended up on dialysis post-operatively, but they were very close to being on dialysis and their kidney had to be completely removed. It was a giant mass. So almost never is it a situation where you were not on dialysis preoperatively and you end up on dialysis because your kidney was removed. But much more common is you never knew a nephrologist. You didn't even know that what a nephrologist was preoperatively, and now you need a nephrologist postoperatively. That's very common. So that's a lab that I will pay attention to postoperatively, both immediately after surgery while you're in the hospital, and then when I follow up with you in the office. As long as your labs look good immediately postoperatively, I'll probably won't check that again for 3 to 6 months to see how and things end up. You do get IV fluids during the surgery, so that kind of improves your renal function. And so when people go back to their normal dietary habits, there can be some dehydration that causes the renal function to get worse. So that's a big important thing to know, that this is the time to hydrate when you get home. Do not restrict fluids. You should be generous with the fluids, not alcohol or caffeine. Those are okay in moderation. 1 to 2 drinks a day is not a big deal of either. Okay, as long as you're fully recovered, outside of 30 days. Within 30 days, I would probably avoid alcohol. But outside of 30 days, when you're kind of back to normal, it's fine to have 1 to 2 drinks a day of either. If your kidney function is normal, you also can still use ibuprofen. There is kind of this big myth that if you only have one kidney, you can't use ibuprofen. That is not correct, unless it is really about your function. If your kidney function isn't great and you have a nephrologist and they're saying no, then that's different. But if your kidney on the other side is working great and you don't have chronic kidney disease, you can continue to take ibuprofen. But hydration is very important. And so about follow-up, just a little bit about follow-up. I'll see you in the office 2 weeks after. We'll review the pathology. Most of the time, this is a one and done and you don't need anything else. With a radical nephrectomy, though, sometimes the masses are pretty big and sometimes they are extending outside of the kidney. And that is the situation where I would get a medical oncologist involved to maybe consider a medical agent that reduces the risk of you having a recurrence. And that would be something we would talk about after the pathology comes back in the office. Most of the time, that's not needed. After a nephrectomy, radiation is pretty much never needed. It's really just a situation where is there a medical agent, and it's not a like hardcore chemotherapy agent that we use in this scenario. It's one of the much newer medicines that have minimal side effects that lowers the risk. So that would be a discussion in the office. So we have that 2 week follow up. We discuss the pathology, see if we need to get medical oncology involved. There are staples. We remove the staples. And then I usually see people 3 to 6 months after with a set of scans. And you will need to be followed for at least 5 years after this surgery by usually a urologist to make sure that you don't have anything come back. And you get scans, it's every 6 months for the first year, and then it's once a year for 5 years. So you still have to come and get those scans to make sure it doesn't come back. And that's basically it for radical nephrectomy. If you have any questions, just please call the office. Thanks.